All right, Dr. Verma, I think we can get started. Thank you, everybody, for joining us this morning. I am Susan Lautenbach with SK Life Science and also volunteer here at Epilepsy Awareness Day at Disneyland. I will be monitoring the chat for Dr. Verma as he goes through his presentation on sleep and epilepsy. And it's with great pleasure that I do get to introduce Dr. Verma. He's the director of the epilepsy program at Houston Methodist Hospital in Houston, Texas. And Dr. Verma, you can take it away from here. Thank you very much, everybody.
Yeah, thank you, Susan, for the introduction, and thanks for inviting me to be part of this special event. I'm sure most of us would feel better if we were in California, but unfortunately, we are not.
I would agree with you. It's a different environment when we're live.
No, sure. And so I've been, tasked to give this presentation on sleep and epilepsy. The sort of the outline of the presentation that I'm going to use is I'm going to talk, about just normal sleep architecture. I'm going to try to highlight some sleep disorders that can be oftentimes mistaken for epilepsy. We'll then talk about epilepsy and the effect that sleep can have on epilepsy, and then other issues surrounding the two of them together. And so I think the presentation will probably be like around 40-45 minutes, and I'm assuming we'll use the rest of it then for questions after that.
That's correct. That's correct.
Great. So let's go ahead and dive in here. So this is obviously, an observation that is millenniums old, but holds true to this date. And so basically it says a patient with epilepsy should spend the day awake and the night asleep. And if the habit be disturbed, it is not so good. Worse of all, when he neither sleeps night nor day. I mean, I think we've known for a long time that sleep can have a profound effect, on epilepsy. And as we go through this presentation, I mean, and I know that there's a lot of caregivers, patients on the line, that it's very, very difficult because, a lot of the medications that we use have sedating effects. Some of the medications that we use can cause insomnia or difficulty sleeping at night. And oftentimes, the sleep-wake cycle is disrupted and, sometimes is completely upended. And so whatever we can, I think you'll realize towards the end of the presentation, which is that whatever we can do to sort of normalize sleep in a patient that has epilepsy is going to really make a significant impact on the treatment of the seizures in that particular patient. So this is, so when we do what is called an actigraph basically is like a movement sensor. It's a wristwatch that people wear. And this basically records movement. So if you're moving, the watch is going to record that movement. And then when you're asleep, obviously there's going to be no or little movement. So you can see here, this is just the plot then from an actigraph. And so during daytime hours, 6 a.m. to sort of midnight, you can see here there are periods of increased movement. And then sort of between midnight and 6 a.m., there's virtually no movement. So it's like lighter. So this is what we would, call a normal circadian rhythm. A circadian rhythm is basically the sleep-wake cycle for a particular patient, which is when are they awake, when are they asleep. And so this device called an actigraph can really help us sort of define what the circadian rhythm of a person is. Now, if somebody has insomnia, obviously during this time here where it's between this midnight and 6 a.m., you're going to see a lot of activity like this. You're going to see more movement. And if somebody just had a seizure, for instance, you might see some, flat areas like this and then activity pick up again. So this is a good way to sort of identify what the sleep-wake cycle of a patient is, what a person is. I mean, obviously a simpler way to do this even would be to just have the patient record on a piece of paper, what time do they go to sleep, what time do they wake up, and we would use the term sleep diary, for that particular record. But if we want a really more objective look at what a circadian rhythm in a person looks like, then you really need to do an actigraph. And this is what a normal circadian rhythm in a patient would look like. And then if we hook the patient up, to EEG electrodes and did a so-called sleep study where we then monitored what stages of sleep does the brain go through when the person is, going from wakefulness to sleep, you'll see, kind of like a cycle here. So the person is awake around 11 p.m., they go to sleep, and obviously you go from sort of like the lighter stages of sleep to the deeper stages of sleep. So stage 1, 2, 3, 4, you kind of cycle back up. And then you see REM sleep, which is rapid eye movement sleep. So the person stays in REM sleep for some period of time, and then they sort of cycle back and forth. And so in a normal sleep cycle, in somebody who does not have a sleep disorder, this is what you would expect to see. So you would see normal cycling between REM and so-called non-REM. So REM is obviously the rapid eye movement sleep, which is in dark black, this bar here. And the rest of the sleep is called non-REM sleep. And so the person basically would cycle between REM, non-REM, non-REM. And typically during a night, you're expected to see around 4 cycles like this. And the other interesting thing is the bulk of REM sleep. REM sleep is is the stage of sleep that we also dream in. That the bulk of REM sleep tends to happen during the second half of the night, and the bulk of so-called slow wave sleep tends to occur during the first half of the night. Why is this relevant? I mean, we'll talk about this when we come to the later part of the presentation. But the reason this is relevant is because seizures tend to occur during slow wave sleep. REM sleep is oftentimes protective for seizures. So when somebody who has epilepsy has seizures, oftentimes they have them in the first half of the night rather than the second half of the night. I mean, obviously these are generalizations. There still is a slow wave sleep that occurs during the second half of the night. And then there are some seizure types such as, generalized tonic-clonic seizures upon awakening that occur in the early morning hours when the patient wakes up. But in a broad sense, when we're getting a seizure history from a patient, oftentimes their seizures are going to occur during the first half of the night, and that's because the majority of slow wave sleep in that person is going to be in the first half of the night. And so how do we look at EEG during a sleep study? A PSG is a polysomnogram. So, for those of us who look at EEG quite a bit, I mean, the EEG is typically more spread out because we're trying to look at, the presence of spikes and spindles, and so on. But during a sleep study, we are really more concerned about just sleep architecture. Is this slow wave sleep? Is this REM sleep? And so we basically compress the data down, 3 times. So the EEG looks very much squished. And so, and I think I mentioned this because oftentimes, patients have sleep studies done, and then they come to us and say, well, I don't think I need another EEG because I already had a sleep study done. The purpose of a sleep study really is to look at sleep architecture, not to look at epileptiform discharges or look at seizure. I mean, we might be able to capture them, but there's typically not enough electrodes on the scalp, and certainly the data is compressed enough that most people are going to miss, small findings on a sleep study. So, I mean, if there's a physician you're seeing who's ordering a, EEG monitoring study, just because you had a sleep study done may not be enough because it's just not going to provide them with that information that they need to manage the epilepsy. And oftentimes sleep studies are read by pulmonologists, not by neurologists, so that's another issue. There's a variety of different sort of frequencies, of brain activity that we look at. And the range, obviously, of activity that we're concerned about in adult patients typically is the slower frequencies, the delta sort of theta range frequencies. especially if they are focal, because they can then pinpoint abnormalities for us. So let's talk a little bit about events that happen during sleep. So it's not unusual again for us to see patients in the clinic who have unusual events during sleep that they are unaware of, especially. Sometimes it's as clear cut as them having generalized tonic-clonic seizures. Oftentimes, unfortunately, it is not. Oftentimes, we get a history of the person just waking up confused and so on. So when we get a history of a patient in the clinic with these paroxysmal nocturnal events. Nocturnal obviously means nighttime. Paroxysmal means events that come and go. Obviously, if they're stereotyped, meaning if they're the same every time, nocturnal seizures really jumps right up to the top of the list. But there's a lot of other sleep disorders, and there's something called parasomnias. Parasomnias are basically events that are sleep disorders that occur while the patient is asleep. And so these are undesirable physical events, experiences. They're episodic disorders. Oftentimes, they're sort of inappropriate release of behaviors like sleepwalking, where the person walks around in their sleep. They're still out of, they're still asleep basically. REM sleep behavior disorder, or RBD, where the person might act out their dreams. Oftentimes, the dream enactment is somewhat aggressive. So if the person is in bed with a bed partner, they might actually injure the bed partner because they might punch that person or kick that person, and so on. There are other disorders such as sleep-related eating disorder, where the person might get out of bed, they're still asleep, walk around the house to the kitchen, and then eat something. So sleep-related eating disorder is a situation where people are not going to go into the refrigerator, make a sandwich and then eat that sandwich. This is going to be a situation really where they're eating uncooked food, sometimes toxic stuff. They might, unfortunately get a hold of chemicals, try to drink or eat those chemicals. So if somebody has sleep-related eating disorder, I mean, it's not where they're waking up and eating, normal food. They can actually eat something that's fairly toxic and then hurt themselves. These parasomnias, even though these are these paroxysmal events, oftentimes don't produce a complaint of insomnia or a complaint of excessive sleepiness, because again, the person is still quote unquote asleep, and these are not going to happen every night. So it's going to be unusual for them to cause something like this. There are some movement disorders that can also occur in sleep, and I'll talk about in a little bit. And then obviously, if somebody has obstructive sleep apnea, um, that will present somewhat differently. I mean, patients that have obstructive sleep apnea oftentimes have heavy snoring, but what might confuse like a caregiver who's not a healthcare professional or who hasn't seen this before is that they might choke or gasp for air in their sleep. Sometimes they might have a little bit of twitching or jerking during those apneic episodes. And the interesting thing is that patients that have sleep disorders, especially things like obstructive sleep apnea, oftentimes can impact the control of a person's seizures. So, I mean, one of the first things I do actually, if I see a patient in the clinic who is complaining of sleepiness, after we've just started a medication or even otherwise, is we always do a very quick sleep history to find out if they have any kind of sleep disorder, insomnia, or especially obstructive sleep apnea. But I mean, there's a list of things that go through our mind, and obviously, depending on what the patient or the caregiver describes, I mean, that's going to help us narrow down whether this is a nocturnal seizure or a parasomnia. And sometimes it's very difficult to determine, in which case we obviously end up doing testing. So when we talk about parasomnias, I mean, there are disorders of arousal. So patients who are in non-REM sleep sort of have an abrupt transition towards wakefulness, but the patient continues to stay confused. So things like confusional arousal, sleepwalking, sleep terrors, I mean, those are all examples of disorders of arousal. Parasomnia is associated with REM sleep. I mean, obviously the main one that we think about is REM sleep behavior disorder. I mean, there are others also like sleep paralysis, nightmare disorder. I mean, sleep paralysis is interesting because this is a condition where when the person wakes up from, in the morning, I mean, their eyes open up, but they feel like they're paralyzed and they can't move. And that can be a very, very unnerving sort of situation. But again, with seizures, typically you're going to see positive phenomena, right? Where the person is sort of shaking or twitching or what have you. With sleep paralysis, the person is just paralyzed and then all of a sudden they just snap out of it. And then there are a variety of other sort of parasomnias, but the ones that really get confused with seizures the most are going to be the confusional arousals and the REM sleep behavior disorder. There are sleep-related movement disorders that can oftentimes be difficult to differentiate from seizures. And really the most common one is something called rhythmic, sleep-related rhythmic movement disorder. This is a situation where, and typically this is a childhood type, disorder that you're going to see where the baby might be in a crib and all of a sudden they just start rocking back and forth and might be hitting their head, against the side of the crib, and then it abruptly stops. Again, really the only way to differentiate this would be if we had an EEG running at the same time, or I mean, sometimes behavior, because seizures are going to follow the typical progression of, the initial tonic phase where the person stiffens, followed by the tonic-clonic phase where they're twitching and jerking. Whereas rhythmic and the tonic phase, that initial phase, typically is where the person's back arches back. Rhythmic movement disorder, the person is going to really have more of sort of a flexion extension type movements. But needless to say, there are several sleep disorders that can be mistaken. And really the main way to differentiate these would be to do either a sleep study and to capture one of these events, or to do an EEG and capture one of these events. And so again, nocturnal seizures can be difficult to differentiate from parasomnias. I think in this day and age, it's a little bit, I don't want to use the word easier to differentiate because, but still, I mean, we now have the ability to do, extended EEG recordings, not only in the hospital, but especially in the outpatient setting, where we can really record EEG activity with video for days on end. I mean, 3, 4, 5, 6 days, and so that gives us the ability certainly to be able to capture some of these events. But one of the issues that comes up obviously is that, especially if these are sleep-related disorders, oftentimes the EEG can be obscured by abrupt movement, which can make this differentiation somewhat difficult. So this is just an example, of something like this. I mean, you look at the left-hand side of the screen, this is normal sleep architecture. These are spindles, vertex waves, which sort of tells us that this is at least stage 2 sleep, if not slow wave sleep. It's a little too short for us to be able to define whether this is slow wave sleep or not. All of a sudden, there's an abrupt awakening where the person wakes up. There's all this sort of like muscle artifact from the person being very tense. And you can see here, I mean, it's all virtually impossible to figure out if this is a movement disorder versus if this is a seizure. And so how will we differentiate? Obviously, we're going to be then looking at the EEG after the event is over. We're going to be trying to look at abnormal findings that we can identify outside of these events. And certainly, the video is really going to make a big difference in terms of helping us determine whether this is a sleep disorder versus this is actually a nocturnal seizure. Which brings us to this point of, so if we're saying that if we can't really tell, if this is a movement disorder or a parasomnia versus a seizure or a nocturnal movement disorder, how do we actually determine this? Obviously, we use EEG. The problem with the EEG, obviously, is that it's not the be-all, end-all, in terms of diagnosis. And there's quite a bit of confusing information regarding the yield of intraictal and especially intraictal EEGs. It has somewhat to do with the definition, that we're using of epilepsy, the interpretation in terms of who's doing the interpretation of these recordings. But if somebody presents to us, and we're faced with this scenario where we really don't know whether this is a sleep disorder, a seizure, or something else, I mean, we do a routine EEG, and it's going to yield positive results just around 50% or less than 50% of the time. And when I say positive, we're talking about like an unambiguous epileptiform discharge that tells us, okay, this person probably has epilepsy. If somebody has repeated EEGs, that can increase the yield to like 80 to 90%. But even in long-term studies, there's this very interesting study, video EEG monitoring study by Ted Walczak when he was at Columbia, looking at a mean duration of almost 7 days of monitoring, and still just under 20% of patients had normal recordings at that. I mean, these were patients with established diagnosis of epilepsy. Again, there's other things that can influence the yield of intrarectal discharges. They oftentimes are more common in children, oftentimes more common in patients that have temporal lobe epilepsy. Then there are certain medications that can sometimes suppress intrarectal discharges. So, I think a lot of times the physicians are reordering studies. Really the reason is because they still just are concerned about a diagnosis of epilepsy, but just haven't been able to prove it. And so oftentimes that's one of the reasons. Now, if we do, capture an intrarectal discharge, it is remarkably unusual for that person to not have seizures. I mean, many studies have shown that intrarectal discharges will be rare in individuals without epilepsy. Now, one of the problems with this, obviously, is that it goes back to the interpretation. So there are many findings on EEG that can look somewhat abnormal and can be misinterpreted as being abnormal findings. So, you have to use both, but if there is a clear, unambiguous epileptiform discharge, it is unlikely that that person doesn't have epilepsy. I think the problem that comes in is that sometimes these EEGs get done for headaches or indications that have nothing to do with seizures, and then somebody looks at the EEG and they see a finding that is considered normal, but they interpret it as abnormal. That's when we really come and get into a bind, because we see many patients where the situations like that, where they get started on anti-epileptic drugs, have never had a seizure in their life, and then leads to us trying to make a decision about what to do with their medications. What about the effect of sleep on epileptiform activity? So there's quite a bit of data actually that shows that intrarectal epileptiform discharges accentuate or increase during non-REM sleep, and especially after sleep deprivation. And I'm sure, many of the people who are on this, attending this symposium will recognize that sleep deprivation is clearly one of the most common causes of seizures and otherwise somebody who's controlled. We used to use the term breakthrough seizures. I guess we really try to avoid using that term now. But sleep deprivation is one of the most common causes, and that's one of the things that we enforce or reinforce in our patients the most, is to try to get as normal a nighttime sleep as possible. It turns out that, again, as I mentioned before, that there's two main stages of sleep. There's the so-called non-REM and REM sleep. REM sleep, on the other hand, which again we talked about before, is typically during the second half of the night. REM actually sleep is oftentimes, it has a depressant effect on intrarectal discharges, and that's why when patients have seizures, they oftentimes have them in the first half of the night versus the second half of the night. And this REM is, and when we review EEGs in surgical patients, oftentimes we use actually this REM depression as a mechanism to identify where the focus is, if there's multiple foci of epileptiform activity. Because if there's an area where the spikes are still present or more active during REM sleep, then that might identify that particular area, while the other ones might not be relevant from that for that particular patient. And again, just to look at the different two stages, non-REM sleep versus REM sleep. So non-REM is typically a seizure promoter versus REM is a seizure inhibitor. There's synchronization of EEG during non-REM, more frequent intrarectal epileptiform discharges tend to be wider in distribution, and then the greatest potential for epileptogenesis. Whereas for REM sleep, oftentimes there's desynchronization of EEG, there's less frequent intrarectal discharges and infrequent seizures. And for those of you who have vagus nerve stimulators or have heard of vagus nerve stimulators, one of the mechanisms by which vagus nerve stimulation is thought to work is by doing like a desynchronization of the EEG, which basically is in effect very similar to REM sleep. So that's one of the proposed mechanisms actually for the vagus nerve stimulator. And again, these are just some EEG samples. I mean, for those of you who are not used to looking at EEGs, the first four channels are the left temporal, the next are the left parasagittal, then right parasagittal and right temporal. These spiky looking things are actually nothing but eye blinks. These are completely normal and this person is awake. This is a sleep sample. This person is now asleep. And then you can see here during sleep, there's this one discharge here, which is in the right temporal region. So this is a spike and slow wave discharge in the right temporal region, clearly activated during non-REM sleep. And it was obviously not present while the patient was awake. And then this is an example of REM sleep. REM sleep is the rapid eye movement sleep. So you see these rapid eye movements in the front. The background is low voltage mixed frequency. And then again, relatively quiet in the temporal region during REM sleep. The other interesting thing, I mean, is that you can really get very technical about this, but even the morphology of these spike discharges, so spikes are obviously an indicator of epileptogenesis. I mean, they're abnormal discharges that are generated by the cortex that we record on the scalp. And you can see here actually that there's some very, very interesting studies looking at non-REM versus REM, and you can see that there's clearly was something called the CSP, which is a composite spike parameter that makes it, the spikes change in morphology, and they're more epileptogenic during non-REM sleep versus different other stages of sleep and wakefulness. The distribution of these intrarectal discharges. This is a very interesting study with intracranial electrodes, with recordings off of intracranial electrodes, showing the spatial distribution of these spikes. And clearly during non-REM sleep, they tend to become wider in distribution versus while the person is awake. We talked about this, a little bit earlier already, that non-REM sleep tends to be more activating for seizures versus REM sleep. But even if you look at the breakdown between REM, non-REM sleep, so stage 1, which is drowsiness, stage 2, and then stage 3 and 4, which is the so-called slow wave sleep or N3 sleep. It's really stage 2 out of these different non-REM stages that is the most activating for seizures. So that's obviously, what I just talked about a little bit was just in normal sleep. I mean, what happens to different seizures? Sleep deprivation is basically an accentuator which is on top of that. So sleep deprivation oftentimes can accentuate epileptiform discharges. And these sleep deprived EEGs, that's why we do sleep deprived EEGs, so that we're going to have a greater yield than EEGs just with spontaneous sleep. One of the things, we always tell patients, obviously, is that, especially when we do EEGs in the lab here, is that when we do sleep deprived EEGs in an individual who's been otherwise completely, seizure free for a period of time, we always recommend that somebody drive them to the lab. And the reason for that is obviously, number one, we don't want them to fall asleep driving. But the second thing is that these sleep deprived EEGs can actually increase the risk of having a seizure because they can increase the yield of these intrarectal discharges. I mean, this is the last line on this is is a little contradictory. I mean, it's a little confusing to put it here, but I put it here because there was a very interesting study done by Beth Mallow when she was at, I think this is from the Cleveland Clinic, where we routinely do sleep deprivation in the epilepsy monitoring unit to try to provoke a seizure. What she found was that if you sleep deprive somebody consecutive nights, uh, oftentimes the first seizure still occurs at the same time, um, especially in adult patients. So the latency to the first seizure in the epilepsy monitoring unit in adult patients tend to be very similar for adult patients, whether they are sleep deprived or not, versus it does make an impact in the pediatric patients. I mean, but this is one study, it was a small number of patients. And again, this is just looking at the activation of epileptiform activity during these sleep-deprived EEGs, and clearly sleep-deprived EEGs percent activation significantly higher than just the routine EEGs, and then EEGs that recorded spontaneous sleep. Then this is just a slide showing obviously the effect of sleep deprivation in seizures and other sort of stressors and the phenomenon that the patients go through. And if you look at both generalized epilepsy and so-called localization-related epilepsy or partial seizures, the emotional stress is the bright red one, sleep deprivation is the blue one, tiredness is green, and then menstrual cycles is the pink one. So you can see clearly that, I mean, sleep deprivation, especially in generalized epilepsies, can play a major role in provoking seizures or the risk of having a seizure. And it's very, it's not as much of an issue in, I mean, it's still an issue in the localization related epilepsies, but clearly for patients that have generalized epilepsies like juvenile myoclonic epilepsy, Epson seizures, the risk of having seizures in the setting of sleep deprivation is much, much higher in that instance. And again, for different epilepsy syndromes, I mean, there's a lot of different epilepsy syndromes that have sleep-related seizures. This is just a small list, obviously, but you have things like temporal lobe epilepsy, frontal lobe epilepsy, the benign childhood epilepsy with central temporal spikes, or the benign Rolandic epilepsy, juvenile myoclonic epilepsy, and so on. And then if you look at these different, sort of disorders, the primary generalized epilepsies, localization, and then the symptomatic generalized, I mean, it's shown here that obviously intraictal discharges are going to be common in non-REM sleep, uncommon in REM sleep. With the primary generalized epilepsies, the ictal discharges tend to be rare in non-REM and REM. But then they're common with the localization related epilepsies and symptomatic epilepsies during non-REM sleep. I mean, I think this is just a list of some of the very common epilepsy syndromes. I'll just highlight a few of these where sleep deprivation or sleep is a big factor. Obviously, big one is juvenile myoclonic epilepsy. Juvenile myoclonic epilepsy is a type of epilepsy that typically starts in the late teens, early 20s. The first seizure oftentimes is actually in the setting of sleep deprivation and alcohol use. Those are the two big triggers for that disorder. But then when you go back and talk to the patient, they oftentimes will then talk about the risk of having these myoclonic jerks that they have, where they have twitching, or if they drop things out of their hands. And the history of myoclonus oftentimes precedes the seizure, sometimes several years. And then obviously when you do an EEG on that person, they have polyspike and spike and slow wave discharges, which fragment during sleep. Benign localization to epilepsies like benign Rolandic epilepsy, these are typically children. They oftentimes wake up with facial twitching, uh, speech arrest, hypersalivation, drooling, and oftentimes these seizures are in sleep only, and then in about a third of them, the seizure both sleep time and while the person is awake. And then obviously complex partial seizures, especially frontal lobe seizure onset, it's sometimes very difficult to determine whether they have epilepsy or a parasomnia, because like the EEG is oftentimes obscured by artifact, and then they can have really unusual clinical manifestations, sometimes a lot of movements, thrashing, bicycling, laughter, agitation. And depending on where the seizure onset is, I mean, the preservation of, they might have still preserved awareness, and oftentimes the seizures are very, very short. And then there's other sort of sleep, epilepsy syndromes. There's the continuous spike and slow wave during sleep, Lennox-Gastaut syndrome, infantile spasms. And then obviously the sleep can have a profound effect on the EEG. So this EEG on top here is a patient with hypsarrhythmia, 15-month-old girl with infantile spasms. You can see these high amplitude spike and slow wave discharges. And then during sleep, you can see more prominent spike and slow wave discharges now, but also with these periods of voltage attenuation or flattening of the EEG. Let's shift gears a little bit even, and then now talk about just the sleep disorders that occur in patients that have epilepsy. I mean, obviously, the sleep disorders that can occur are the same that can occur with other people. And there's really, we typically divide them into three categories. One is going to be the excessive daytime sleepiness, where the person is more sleepy during the day. We also use the term hypersomnia. There is the second one is something called insomnia, which is going to be difficulty sleeping at night. And insomnia can be both sleep onset, meaning the person has a difficult time initiating sleep, can be sleep maintenance, meaning that they fall asleep, but then they have a difficult time staying asleep. And then certainly you can still have parasomnias, the things that we talked about, where these patients have movements and so on, but they're really a sleep disorder, they're not epilepsy. But obviously if somebody somebody could still have both. It's a little unusual to have both, but they can still have both. And I mean, this is again just a list of hypersomnias that can be seen in epilepsy patients. I mean, again, hypersomnia is going to be the difficulty staying awake during the day or excessive daytime sleepiness. And so of this list, I mean, any of these things can occur in patients that have epilepsy. Obviously, this could be extrinsic, meaning that the sleep environment is bad. There's a lot of noise, outside, noise in the other room. There's a dog in the house, and the dog is barking at night, so you can't go to sleep, which leads to the person becoming sleepy during the day. Or the person is going to sleep at 2 o'clock in the morning and then waking up at 6 o'clock in the morning. Or even if they're waking up at 10 o'clock in the morning, the quality of sleep is just not going to be as good once there's light outside, there's higher noise volumes, and so on. There can be so-called intrinsic sleep disorders, where the person could have just sleep apnea, or could have a central sleep apnea, narcolepsy, and so on. Or they're on medications that can make them tired and sleepy. So when we see a patient in the clinic, I mean, I think that the reason I mention this is because if we're seeing a patient in the clinic and they're tired and sleepy, it may not be their seizure. It may not just be their epilepsy. It might be the medications that they're on, or it might be an internal sleep disorder. So we really need to be able to tease this out when we're seeing patients in the clinic. And then obviously there's insomnia, which is difficulty sleeping at night. The end result is still the same, which is that they have a hard time staying awake during the day. But this is different than hypersomnia, obviously, where their nighttime sleep is otherwise somewhat normal. But again, we talked about the different things. This could be intrinsic, could be depression, could be mood disorders, could be many of the medications that we use, or if somebody's having recurrent nocturnal seizures, that can certainly result in insomnia as well. So how do we assess sleep in somebody who's coming to the clinic? We use a very brief sleep questionnaire, and the questionnaire basically goes like, what time do you go to sleep? What time do you wake up? Are you able to stay asleep? Does your caregiver or the family member or the bed partner notice any unusual things in sleep? Do you stop breathing in your sleep? Snore and so on. And so really within 5 minutes, we can at least get some idea of what the issue is. But if the person does have insomnia, which is very common in patients with epilepsy, 90% of the time it's depression or concomitant mood disorders. And so certainly if we treat that person's depression, that is going to make a significant impact or have a significant impact on their sleep at night and subsequently their epilepsy. So, I mean, a lot of times, when we see patients who have insomnia, I mean, I think patients feel that it's a quick fix. Let's give them a sleep aid, and that'll help with the sleep. But the problem with these sleep aids is that oftentimes they're addictive, and you never want to really treat the side effect of medication or another issue with just a medication. You really want to try to treat the underlying cause. So at least in our clinic, we spend quite a bit of time, talking about sleep hygiene, what to do when somebody's trying to go to sleep, how to maintain sleep, and then how to sort of manage the waking hours. Because there's patients, I mean, who unfortunately can't go to work because of their seizures. So they just lie around in bed, and that is obviously going to be terrible for their sleep. We try typically, if it gets intractable enough where we can't manage it on our own, then we refer them to a neuropsychologist for cognitive behavioral therapy for insomnia. And then another very effective form of treatment is so-called light therapy. I mean, the layman's way of thinking about this is, somebody goes into the room and basically opens up the windows. You let the light in. So another way of doing that is that you can get a light box, from different vendors. They're available online, Amazon, what have you, where it's a very, very bright light that basically mimics, sunlight. And it's oftentimes it's used to help reset the circadian clock. So again, many different treatments that we use for insomnia, but really there's got to be a commitment from the patient to at least manage the sleep hygiene piece. Many of the medications that we use, have effects on sleep. Obviously, the benzodiazepines, other medications can cause the person to be sleepy. And so especially if that medication is available as a once-a-day medication, we encourage patients to take those before they go to bed, so that if they are going to be sleepy, then they just go to sleep after they take their medication. But there are some other medications, and obviously drugs like lamotrigine, drugs like levetiracetam that have been associated with insomnia. Sometimes we ask the patients to take those medications in the morning, but if the insomnia gets bad enough, obviously, then we have to either withdraw the medication or then use different strategies to get the sleep to be better. Sleep apnea, is actually a very common problem in patients with epilepsy, and this is going back 2 decades now in terms of the data available for this. Both Brad Vaughn, who is at UNC in Chapel Hill, and Beth Mallow at, I think she was in Michigan, actually. I made a mistake there when I mentioned her before. So she used to be at Michigan. They found that the risk of sleep disordered breathing or sleep apnea was actually 2 to 3 times the general population. Obviously, there's many reasons. Patients that are on anti-epileptic medications oftentimes have a sedentary lifestyle. They can't work, so they're a lot of times at home. They're not allowed by their family members to go outside by themselves because there's a risk for having a seizure. There's issues related to weight gain, again, lifestyle issues versus many of the medications we use can also cause weight gain. And then it turns out that if somebody has a vagus nerve stimulator, actually that also can increase the risk of sleep disordered breathing. So if somebody has a vagus nerve stimulator, we really need to get a good history of, do they have stridor at night? Or do they stop breathing? And that could be related to the vagus nerve stimulator. But I think it's universally accepted now that if somebody has sleep apnea or any other sleep disorder, really, that can lead to poor seizure control. And that there's good data showing that if you can normalize the sleep by the treatment of the sleep apnea, then that can result in better seizure control. And then this is just, again, showing that this was a study again published in 2007, where patients that had sleep apnea caused actually a recurrence in seizures in patients that had been seizure-free for a while. And then this is also another study by Nancy Fogarty from the Cleveland Clinic, where they showed that, I mean, there were patients who were undergoing workups for epilepsy surgery. And then once the sleep apnea was treated correctly or appropriately, I mean, they were able to defer epilepsy surgery in those patients because the seizures came under much better control. This is just a few last slides, I think, about the vagus nerve stimulator, just to sort of show you the risk of this. Again, I'm sure many patients have vagus nerve stimulators, and I don't want people to sort of freak out when they listen to these few slides, because certainly it's not going to be an issue in the vast majority of patients. And if it is an issue, oftentimes it can be corrected by just changing the stimulation settings. But obviously the vagus nerve stimulator is a pacemaker-like device. You connect it to the left vagus nerve, and then it sort of cycles on and off at a fixed frequency with parameters that we can define. But it has been shown that high VNS settings, in quotes, may cause sleep fragmentation and disruption. Sometimes it can cause stridor, which is basically the vocal cords sort of coming together, and the person can have hoarseness. And then it can sometimes exacerbate underlying sleep apnea, and it sometimes can be difficult to titrate the CPAP if they have vagus nerve. Really an easy fix, not an easy fix, but a lot of times the fix for this is that you basically reduce the frequency of the device, or you can increase the pulse width, and then that oftentimes that helps resolve this. And if it can be resolved, I mean, the other trick is that if somebody has a magnet, they can tape the magnet over the device at night, so that basically will turn off the vagus nerve stimulator for that period of time, and then they can remove the magnet in the morning. And this is just to show you, how the vagus, this is a sleep study. This is the arrow points to kind of where the VNS turns on, and you can see here that there is some reduction of airflow at that point, indicating an apnea. I mean, this is positive information regarding the vagus nerve stimulator, where they saw actually that it reduces excessive daytime sleepiness. So it can have positive effects on sleep as well. So, I mean, I think the conclusion from this lecture really is that so when we see patients having nocturnal events, just because they're having nocturnal events doesn't make it a seizure. And so not all that shakes at night is a seizure. Sleep deprivation or sleep in general can affect epileptiform activity and may help in the pre-surgical evaluation like we talked about. Some of the treatments that we use actually can cause sleep disorders, so we all need to be aware about those. And certainly recognition and treatment of sleep disorders can help with seizure control. So I will go ahead and stop here and take any questions that you guys have.
Thank you, Dr. Verma. Yes, you've got a lot of questions to get
Okay.
to. And the first one, I'm actually going to ask Amanda to come off mute because you wrote a comment, is that only in the sativa VNS? And then you followed up with another question, what about clobazam and VinPad? But the first part of your question, if you could clarify that for Dr. please. Thank you.
I'm sorry, can you repeat that, Susan? I'm sorry. Let me get to the chat part here. Okay, so can you repeat that actually, Susan, if you don't mind?
Yeah, so Amanda asked, is that only in the sativa VNS? So, and that was early on in your presentation, so I didn't caught the context, so I asked her to come off mute.
No, I think this is older information. So this is really based on the original, the 103, 105 studies, yeah.
Okay, because I have the 106 SR, so I was just wondering if that information related to the new model, but no, if it's older data, then that's cool.
Yeah, so I mean, I think but I mean, I think if you have sleepiness, I mean, the new VNS devices in theory are very similar, right? I mean, they just have the open loop part where there can be seizure detection, but the basic working of the vagus nerve stimulator is still very similar. So if somebody has noticed, that you snore at night, or if you have some stridor where they hear like a noise where when you breathe, then that's something that you should still bring up with your physician so that it can be addressed.
All right, and my other question was about clobazam and Vimpat. I guess more so Vimpat, because I do take that in the morning, and I find that I am tired like a couple of hours later,
Sure.
and I know that they can both cause drowsiness, but the Vimpat, I take both in the morning and at night. So I was just wondering.
Yeah, both of those medications, can certainly cause sleepiness and tiredness. The clobazam obviously is a benzodiazepine, so it's a sedative medication. We use quite a bit of clobazam in our practice also. And so we typically recommend that patients take it at night to help with, but yeah, both of them can still cause some sleepiness and tiredness, and it could be an effect of the dose that that person is on. Obviously, if you're on two medications that can cause sleepiness, that's going to get compounded, so that doesn't help.
No, it doesn't. And I guess what would you consider like a high dose of clobazam?
So I, would refer you to your physician about that, because high is very variable. I've certainly used above what is the dose recommended in the package insert, but I think for a specific question like that, I would refer you back to your doctor.
Oh, okay.
Thank you, Amanda. We got a couple more questions here, Dr. Verma.
Sure.
From Janice. Is it typical for awakening every 2 hours or so in persons with focal onset aware and impaired?
No, obviously, when people go to sleep at night, they should get a restful, full night's sleep. But yeah, in patients that have seizures, as I talked about, there's a variety of different things that can cause sleep disruption. And concomitant depression certainly is one of those. There's depression that patients recognize, and then there's depression that they don't. 90% of insomnia really is caused by subclinical, or clinical depression. So I would certainly mention that again to your physician, and make sure that they can assess you for that.
Thank you, Dr. Verma. And then we'll go to our last question. They increased my topiramate again, and I'm exhausted all the time. I sleep at night and all day and still feel tired. Is that normal? And then the question was followed up. So in junction to my message above, I take lamotrigine AM and PM, which you said causes insomnia, and topiramate AM and PM, which make me tired. So I have two meds doing different things.
So these are obviously tough questions. I expected only easy questions during this symposium.
Welcome to Epilepsy Awareness Day at Disneyland. Never an easy question.
I think, I think if you talk to, 100 patients that are on lamotrigine, there's 80% are going to say they're perfectly fine. They have no insomnia. There's obviously, I mentioned lamotrigine because that's one of the drugs that certainly people talk about, having a higher risk of insomnia associated with it. I think, again, that this would really be an issue of dosing, and how you're specifically responding to these two medications. And so, I think you really would need an actual sleep assessment, to sort of figure out what, and to help you establish like a fixed daytime and nighttime schedule. The problem obviously is that if patients are unable to work and are at home, there's a tendency to sort of sleep whenever, wake up whenever, and that can cause quite a bit of sleep disruption, fragmentation, and then can really impact the circadian rhythm, which is going to cause significant issues with daytime functioning and nighttime sleep. So because all of us really require only 7 to 8 hours of sleep. So if somebody is in bed, for 10 hours, that's not good. I mean, because those 3 extra hours are going to result in sleep fragmentation, which is going to make them tired. So they might think that they're in bed, for longer, and that's good, but that's not good because it can cause sleep disruption and then sleepiness during the day. So certainly, I mean, I would reach out to your physician, and because you might really need sleep hygiene, education.
Perfect. Thank you, Dr. Verma. And then actually one more question snuck in, and then we got to wrap it up because our next speaker is waiting in the wings. But from Christopher, my seizures from tonic-clonic to complex partial switched from daytime to nighttime only 3 years ago. My parents have witnessed me stopping breathing. Do you think it can switch back to daytime? Do you think using a CPAP can stop seizures? I was diagnosed with sleep apnea.
Yeah, so certainly, I think, let me just address the sleep apnea issue. So sleep apnea, what happens with sleep apnea is, where we go to sleep, and basically, as we get into the deeper stages of sleep, the muscles in the neck tend to relax. And obviously that happens in all of us, whether we have seizures or not. And as those muscles relax, the airway sort of becomes narrower. And as the airway becomes narrower, eventually it can close down. And so there's no air being exchanged, through the lungs. And that is what we call an apnea. Apnea basically meaning that there is cessation or stoppage of the airflow. And so when that happens, I mean, obviously that's not good. So there's a signal that goes up to the brain and says, oh my God, the lungs have started, there's no airflow, the oxygen level is dipping down, wake up. So basically the brain goes from a deep stage of sleep to a shallower stage of sleep. And then as the brain goes to a shallower stage of sleep, the person sort of has an arousal or wakes up. You don't have to wake up, but the brain basically wakes up momentarily. The airway opens up again, and then the person starts breathing. And depending on the severity of sleep apnea, this can occur 20, 30, 50 times an hour. So it's very, very disruptive to sleep at night. So because of that sleep disruption, that actually increases the risk of having seizures, because that increases the risk of these epileptiform discharges or abnormal, spike and slow wave discharges. And so if you can treat the underlying sleep apnea, obviously you're trying to sort of stabilize that person's sleep and brain activity, and that can really reduce the risk of having seizures during sleep. So certainly if somebody has sleep apnea, using a CPAP machine can definitely make an impact. I'm not sure that it can completely stop the seizures, but certainly if it can control them, and normalize the sleep well enough, it's gonna definitely help with the seizures at night. Now, in terms of the other question that you had about seizures switching, between daytime and nighttime, I mean, that is a little tougher. Certainly, I think if the sleep apnea is under better control, that's going to have a significant impact on the nighttime seizures and daytime seizures, because obviously your sleep is not going to be as fragmented.
Wonderful. Thank you so much, Dr. Verma, for your presentation.
Thank you so much for everybody
allowing
listening.
us to go a little bit over the Q&A, and thank you to everybody that attended this presentation. And remember, these will go live in a couple of weeks, or not live, but they will be recorded and will be put on Facebook Live so that you guys can go and watch it again. If you want some more details to the presentation, you can revisit them. Thank you so much, Dr. Verma.
Yeah, I'm going to say hello to my friend, Dr. Blanca Vasquez. Hello, Blanca.
I am so happy that we're working together again.
Yeah, there you go. Yeah, Bob Knowlton was on before me, so nice seeing you.
I know, I heard it too. What a great presentation. Thank you. I really enjoyed it.
Yes, thank you so much. Take care. Bye.